I think it's really important to standardise the intervention because it's an evidence-based model. I think a lot of the work, especially in the domestic violence and abuse sector, is sort of timely because we keep reinventing the wheel. So we have evidence base and then it doesn't get taken forward or mainstreamed, and then people get funding to do the research again instead of actually using the funding to get the model mainstreamed. So I think by standardising it, we know that it works, we know that it supports patients, it helps professionals do their job. So I think it's really important to use that model and make sure it's mainstreamed. Also, the evidence base for the IRIS model has shown that it's a really successful intervention. The unique challenges we faced in Hackney are around relationship building. We didn't get the opportunity to build a relationship with City and Hackney Primary Care Trust because they had a lot of staffing changes. So in the Bristol side of the project, the public health lead was consistent and also was really forward-thinking about domestic violence and abuse, so quite on board and always keen to meet and be part of the steering group and look at taking the work forward. In City and Hackney, we only got someone along to our steering meeting once. I think in City and Hackney as well, things are a little bit different. You know, often work that's implemented is quite sporadic across different London boroughs. And I think in Bristol, they're quite consistent now around domestic violence and abuse. They've got a really good platform. In Bristol, we had a contact that was consistent throughout the research trial, and it was someone who was really on board and had a real broad understanding of domestic violence and abuse. It meant that things moved quicker, and we got meetings, I suppose, more efficiently, and then we could move forward quite easily, which is different to Hackney, where we didn't have that kind of lead. We're trying to overcome the challenges in Hackney by being more forward-thinking ourselves. Obviously, part of the challenge was about us not recognising enough in advance, I suppose, that these problems are going to occur. So now I've already got a meeting set up with the public health lead in City and Hackney so that we can try and look at future funding and commissioning in the borough sooner rather than later, so that we can see what the issues are going to be and hopefully address them in time, so that when the funding ends, the first round of funding, we can already be looking at round 2 of funding. As opposed to being reactive, I suppose we're trying to be proactive and more organised ourselves. And also now I'm the national lead, I need to build more of a relationship in City and Hackney, because again, I need to be responsible for managing that relationship and then using it to move things forward. I think the role of the advocate educator is essential when we look at responding to patient need. The advocate educator can basically be, any patient can be referred to them, a female patient who has experienced previously or is currently experiencing domestic violence and abuse. There's no criteria really. Any GP or nurse can refer, as soon as they ask about abuse, if they get a disclosure, they can refer the patient straight to the advocate educator. It makes the clinician's job more straightforward, and the advocate educator can then meet with the patient for a much longer period of time, do a safety plan, a risk assessment, and try and source the best type of support that they need.